as critical as having robust infection control knowledge and practices across the acute, post-acute, and long-term care continuum, as transformational as rethinking the fundamentals of the buildings and the living environments we design for frail older adults and persons with disabilities. We have a stellar panel to share learnings and perspectives at the macro and micro levels and at the institutional and human levels. We will touch on learnings around how vulnerable and how robust our systems were, things like supply chain and sharing of infection prevention resources. How vulnerable and resilient our team members were and are, the interplay of facts and emotions, the need to adapt routines in real time, and opportunities for leveraging process improvement. How fragile and compromised our residents were and are, the impact of isolation, separation from each other and family members and friends, and how interdependent we all are, and the value of collaboration and communication in time of crisis. So with the spirit of appreciative inquiry, we ask, how might we leverage these learnings to not just maintain, but to see opportunities to build upon them for the good of our healthcare system, our organizations, our team members, and perhaps most importantly, the people we serve, our residents and their families. And in that vein, we're going to kick off with a focus on resident life and staff support with Paige, Hector, and Bobby Gray.
Thank you. Okay, I think we've got it up. Yes, Alice, see the main screen? Okay. Hello, everyone. I'm so happy to be part of this group. I am a social worker by training, degree, and background. Primarily what I'm doing right now is a lot of work in the space of trauma-informed care and nonviolent communication. So you'll get a flavor of that in my presentation today. So when I really tried to distill this down to what are some main learning points and what I'm seeing in my work and my practice, and I came up with a whole list, but I focused on just two. Number one, trauma is an injury. And number two, tracking power and privilege, it supports collaboration. So what do I mean by trauma being an injury? It's not an incident, it's not an accident. We don't just move on from the pandemic. So however we conceptualize this idea, is the pandemic over or not, when there's a lot of debate about that, the impact of the pandemic is certainly not over. And in my estimation, in my lens, it probably never will be. Brings me to the work of Dr. Gabor Mate in his newest book, The Myth of Normal. He says, trauma is a psychic injury lodged in our nervous system, mind, and body, lasting long past the originating incidents, triggerable at any moment. That really, really spoke to me, and it brings me to this visual. If you were to look at this perspective just from the ground, we really only see what is right in front of us today, on this moment, or perhaps an event in our life. But once you go above the trees, the perspective above the trees shows the connections across a lifetime of events, whether or not you describe or define them as trauma or traumatic or stress-inducing events. The bottom line is this: that trauma can be cumulative and impact a person throughout their life. So as we think about the people that we serve in our communities, this to me becomes even more poignant. Some research that just came out from our colleagues here in JAMDA, this sentence really spoke to me, is that traumatic stress and symptoms can persist and reemerge in older adults as a phase of social, financial, and physical change. I mean, just think about the people that we care for in our nursing facilities and communities. These changes can trigger a traumatic stress response, even for those who had previously been coping well. So we've got this COVID thing, layers upon layers of impact in multiple areas at any moment can trigger stress responses for residents and also for staff. Again, a paper that just came out in JAMDA just this month, a meta-analysis reveals a wide range of persistent long COVID psychiatric symptoms, including anxiety and depression, PTSD, poor sleep, hyperfocus on symptoms, impaired cognition, and OCD. So this is going to be a tough road to hoe, I think, for the next several years. Long-term impact of all of this is significant for all of us. And by all of us, I mean residents, patients, families, and staff, all of us. These are complex situations. They're going to require time, effort, energy, and coordination. So to me, the impact, we really need to be focusing on the impact of trauma on behavioral and mental health. One of the ways that we are doing that is with person-centered trauma-informed care, recognizing the pervasive nature of trauma, integrating principles and practices. So the principles are trauma-informed care principles, care, safety, and trust, and collaboration and mutuality. The practices are where I really want to focus more attention of how do we make those come alive? What exactly do we do at the point of care in our meetings to really embody and integrate trauma-informed care principles? Number two, tracking power and privilege, it requires collaboration. And I believe Erica is going to pop a couple documents from me into the chat box, one of which is this document I recently wrote with a colleague. So just quickly, what is power and privilege? Power is the capacity to access resources. On this call today, there is an incredible amount of power. When I say access to resources to meet our needs, I'm talking about things for choice and efficiency and support, security in a work environment specifically. And resources can be just about anything. Our energy, our capacity, the infrastructure, relationships, experience, of course, money. All of these things are the resources. And the more power we have, the more access to those resources that we have. The privilege is the access to resources that come from groups we belong to. For example, gender, race, class, language. All of these things can also afford us power, access to resources. So why is this important to name and address? It's because it's in order to support the people being free of fear-based motivation and creating environments that are built on trust and shared power, truly embodying person-centered trauma-informed care, one of which collaboration. This is not possible. So we talk about working together in collaboration, but we cannot do this until we level power differences and giving voice to people who historically have not had a say. For example, people from the global majority, people with disabilities, older individuals. So until we learn how those of us in power to invite dissent, invite disagreement, creating a safe place for people to say no. This slide just names a couple things that we can do to actually integrate power and privilege tracking into our everyday work in whatever setting we are, agreeing to name and acknowledge the power dynamics. For example, some ones that we already know of is that people with more power who tend to express their needs and positions more easily than people with less power who tend to stay more silent. Creating space in our meetings, creating space to talk about and for people to share anonymous impact sharing when they're not comfortable because of that fear-based phenomenon that people are frightened to speak up or don't feel that they have power or capacity or choice to do so. And just in closing in 2 seconds, just the perspective on time, trying to shift. We are socialized to believe that we don't have enough time, there isn't enough time. My work, my perspective is trying to shift us from saving time up front and losing it later to investing it and harvesting results later. All right, Bobby, off to you.
Good afternoon. My name is Bobby Gray, and I work for Presbyterian Senior Care Network. I oversee the skilled nursing and personal care across our network. So in terms of trauma-informed care, we only really began to talk about this in an organized way a few years before the pandemic. And we've researched and instituted a formal process to begin discussion of past trauma with new residents at move-in, as well as existing residents, recognizing that this kind of information gathering is not just a regular assessment like you do for falls risk, say, but this is one you tease out over time as you build trust. We've also developed and conducted training for our team members. And I can tell you, we've been surprised at the extent to which this training has been a trigger for team members. And this has caused us not only to adapt the training and provide upfront warnings, but also to work on how we sensitively address team member trauma and what they may encounter in the workplace. In terms of COVID, the strategies we implemented to keep residents safe, no visitors, no dining, no activities, no beauty shop, quarantines, therapy in your room, all made sense at a time when we were talking about flattening the curve and never expecting this was going to go on as long as it did. And while we knew the residents would miss these things, we thought we were doing well to do window visits and outdoor visitation station and virtual visits and hallway bingo and a lot of communication with families. But despite this, we recognize now the effects of isolation were tremendous. One resident commented that she now understood how her husband felt as a POW during World War II. So that, I think, says quite a bit. So a few takeaways for the future in trauma-informed care, I think, are we need to consider a better balance between risk and quality of life. We advocate for liberalized diet given people's advanced age in the interest of quality of life. But how do we need to advocate for people just not getting sick, but also adding value to life? And second, even before the workforce challenges post-COVID, we tended to spend more time and focus on clinical services and long-term care to the detriment of social services and those who provide recreation. If you just take a look at the starting rate for a nurse versus a social worker or a rec therapist, it's startling. And third, we need to reframe person-centered care, I think. The 4 M's, including what matters, is such a more cohesive and comprehensive approach, I think, than we've tried before, with a lot of focus on just choice and environment. So I think if we do these things, perhaps we can avoid future trauma to our residents during, things like a pandemic. In terms of power and privilege, I have 2 reactions. First, at a high level, long-term care, I think, is the stepchild of healthcare. It's a service nobody really wants. Everyone wants to live long, die fast, and do that at home. So it's much easier to talk about home and community-based services in formulating state and federal budgets. This ongoing underfunding of skilled nursing was bound to reap the rewards of the pandemic. So more advocacy efforts on our part, of course, is called for, but also more collaborations with health systems, I think, is key. In Pennsylvania, we had a series of 3 state-funded regional initiatives during the pandemic. The first provided emergency assistance, PPE, staffing, technical support. The second iteration focused more on prevention and ongoing support. And now this has evolved in the third iteration to provide initiatives on workforce resiliency, including focus on the IHI Joy and Work program and the 4 M's, as well as infection control. So I think it's a unique way to forge health system long-term care partnership to leverage their expertise and resources. In the same vein, we're now working with another health system to develop a new niche in dementia care, specialized short-term rehab for those living with dementia, and medication management to keep people out of inpatient psych and at home longer. We're finding health systems much more willing to partner now and cognizant of the impact of not having enough skilled beds is to their ability to discharge and admit new patients. So these partnerships can help share the power of the health system with the long-term care providers. My second point is at the nursing community level. Culture change taught us about inverting the org chart and having those providing direct service to the resident on top, not the traditional hierarchy of command and control. I think that's a nice vision, but we have trouble operationalizing that. And certainly during the pandemic, top-down direction was necessary. For example, our corporate communication with our leaders from the start of the pandemic was a daily call, emailed minutes, attachments to cascade to their teams as life changed minute by minute. And that was necessary. But this has evolved now into a huddle process where all team members, all of them, have access daily to our leaders, including our officer team, to escalate concerns. We focus a lot around safety through a series of tiered huddles. We say that problems are good, and we encourage everyone to identify them in a culture of psychological safety. We solve them with people closest to the work, and they identify barriers where they can't do that. This put the power back in the hands of those next to the care and responsibility on leaders to remove barriers that impede them. I think the meaningful work that people seek is to be part of the solution, to have power. Our lead CNA program is an example of that. We're piloting a lead on each shift in each neighborhood to smooth shift-to-shift communication, serve as a help chain to other CNAs, champion 4 M's work, interview potential team members, and otherwise communicate that physical and psychological safety is important to our organization. So that's my comments on that, and thank you very much.
Fantastic. Thank you both. That's wonderful context setting and examples of, the big picture and then, the specific work in the nursing home. So thank you so much, both of you. Now we're going to hear from Morgan Katz and from Chris Winston about some of their framing around these issues and innovations that came out of the pandemic. So Morgan, over to you.
Thank you so much. And thank you so much for having me here. So I'm Morgan Katz. I'm an infectious disease physician at Johns Hopkins, and I have focused my research pre-pandemic and certainly through the pandemic on infection prevention in long-term care facilities. So I promise that I did not talk to Bobby before this talk, but I want to echo so many things that she said. I 100% agree. So I would say the one overarching thing that has come out of this pandemic is that connections have been established. So pre-pandemic, we were not having regular conversations between public health, acute care hospitals, and other regional healthcare systems. But during the pandemic, this was absolutely necessary. And we really did see the birth of an at times beautiful collaboration of private-public partnerships responding to the emergency. And I would say this is the one thing we cannot lose moving forward. And remember that before the pandemic, the only conversations going on between facilities were often between the case managers at the acute care hospital. And a lot of those conversations were about insurance status or billing. And we weren't sharing some of the more important information like COVID status, vaccination status, MDRO colonization, all things that directly impact patient care and also public health. So I just want to highlight a few examples that came out of the pandemic due to the success of these new relationships. So in Maryland, through our Maryland partnerships between acute and long-term care, we created a very brief one-page transfer form that is now used between every skilled nursing facility and hospital in the state that clearly displays the patient's infectious status, colonization, antibiotics, and their intended duration listed on them. And these are able to help us make sure that patients were vaccinated in the correct amount of time, they were isolated appropriately, and it also contributed to antibiotic stewardship efforts, which is going to be a big issue in the coming years. In the height of the pandemic, we were also using some of the relationships to rely on some of the ample resources that we had in acute care that weren't filtering down to long-term care, such as sharing fit testing with nursing homes, lab capacity, testing and clinical staffing efforts. And in Maryland and many other states, as Bobby said, we saw the emergence of these strike teams, which were a way to provide support to nursing homes without them worrying about surveys or other issues. We also saw these regular public health calls with long-term care partners. These were weekly early in the pandemic and may not be as frequent once the state of emergency is over, but at least we're still sharing information regularly, and these can be hugely beneficial in the setting of new infectious pathogens and to discuss other emerging public health issues. So the best thing that facilities can do here is to continue their relationships with not only public health, but also acute care to collaborate, share resources, to know their contacts, and to use them in the next emergency. We all need to remember that we have a shared patient population, and care is going to improve if we maintain these connections. And I think that the CDC has actually identified the need to address this and is now devoting funds to create this nursing home public health response network. So one of the missteps and the delay of getting information out about transmission in nursing homes early on was that many of the academic centers did not have a research presence in long-term care. So there was really no way to get data in this setting with a short turnaround time. So this has prompted CDC to invest time and money into establishing and maintaining academic and long-term care relationships so that they can get information quickly and respond appropriately to new variants or new infectious threats. And it's really intended to create these nursing home cluster sites across the country who partner with academic medical centers and are actively involved in various studies to provide real-time data and research to the CDC, and also who can rely on some of the acute care resources when needed. So I'm really excited to see how that partnership develops, and I hope it's going to continue to encourage facilities to partner with other health systems and improve the continuum of care and keep research happening in these settings so that we actually do understand what is feasible and how long-term care works. One of the final points I'll make is that I would add that some of the more successful facilities that I saw coming out of this pandemic, what they adopted for emergency preparedness is a clear system of communicating with family members and residents and doing it often. So the facilities that failed to do this are the ones now suffering with legal issues, disgruntled family members, or residents. And I think this is such an important concept to avoid. Communication is just so important to avoid some of those challenges. Obviously, a lot of the legal things coming out are because family members did not know what was going on inside the facilities. So I think I'm at time. Thank you all for your efforts for the last few years, and I'm excited to hear Chris's perspective from inside the nursing home. Thanks again.
Wonderful. Thanks, Chris. Over to you.
Hello, can you hear me?
Yes.
Good afternoon, everyone. How are you all doing? One thing, and first I want to start off introducing myself. My name is Chris Winston. I am in the facilities of DC. I am a facility manager that manage the maintenance department and environmental service. So I'm going to talk a little bit about the beginning before COVID-19. And one thing that I want you all to take out of this is DC began citywide emergency preparedness back in 2008 through the Emergency Management Coalition. And long before EOP, the Emergency Operation Preparedness, or either the ROP requirements was started in 2016. The facilities back then, we were being surveyed on our emergency preparedness to make sure that we were in line with things of the nature of sheltering in place versus evacuation, natural disasters versus man-made disasters. But also what we did, we had a group of people that we had a planning committee. We worked with work groups. We worked with the DC Healthcare Association. Also, we had inputted the healthcare information system, which is a radio system, a computerized system that we will go on and be able to have communication with our colleagues or either the coalition. Also,
Chris, I'm sorry to interrupt. Could you just speak up a little bit? A few people are having trouble hearing, or if you want to increase the volume on your computer, we can hear you just a little louder.
Okay.
Thank you.
Okay. So also working with our stakeholders, and we had many stakeholders that was with our organization, which was the Hospital Association. We had the ambulance, we had the morgue or the medical examiners, and the dialysis and shelter centers. Also with fire, MPD, and public relations. So with all of this combined and starting this so far ahead, when COVID-19 came on us in 2019, the challenge was minimized. And the challenges was minimized where we had issues just getting vendors to release orders in a larger quantity. Dealing with examples, trying to get more face masks, unvaccinated vendors not allowed into our communities to perform just simple things as dropping off our supplies. The big thing that hurt us was we were unable to inspect our devices, as far as our life safety devices and things of that nature. So that put us back a little bit on getting these jobs performed. But I heard the person before me speaking and saying that family visitation was a problem. That was a big issue for us. With families not being able to come in to see their loved ones, especially during the time when their loved ones was sick. So we had to make sure that we had to be compassionate and get them in to see their family members. What did we do for the emergency pandemic preparedness? We contacted our outside agencies. We worked with our DC Healthcare Association. We worked with the Department of Health. Of course, we worked with the stakeholders within the coalition. We met weekly. example, with the hospitals, when we needed additional supplies, the hospitals was there for us. But something that came out of this in the beginning when we started back in 2008, the Hospital Association gave us grants where we were able to get stockpiles of N95 masks. And from us being able to get them stockpiles of N95 masks, so when the COVID-19 came, we had supplies that we can start off with and was able to move forward. One thing that we were doing that, we had to set up quarantine units with zip walls and install partitions to protect our staff and vendors. Each department provided the staff, vendors, and visitors with a training and education on entering and exiting the building. The facility followed the emergency operation preparedness on preparation and planning for the start of COVID-19. The facility created a supply list of the valuable items during the pandemic and allowed man hours to manage these certain items to make sure that they were distributed properly. Also, what we looked at, we had a problem with air purifiers. So what we did, we provided standalone air purifiers to purify the air in the areas that we did not have COVID-19. And that assisted us very well. Where are we now? Vendors are able to accommodate us with supplies in various amounts. Vendors can enter our building for emergency services and calls. Continuation of symptom checkers, i.e. our AccuCheck system. Utilizing private rooms for isolation instead of zip walls. But most importantly, restoring the facility to its previous capability. Recovery efforts are a concern with the issues of decision that must be made after immediate needs are addressed. Primarily, focus on that involve policies, procedures, equipment that will allow our facility to conduct normal business. Continuous education, working with the committees that is established by our coalition. Any questions?
Oh, that's great, Chris. Erica, I think we can probably take the slides down. That's great. Thank you so much. Having met you in person this week and then hearing all of that content was really wonderful. Thank you. And I just want to draw people's attention. There's a very active chat going on, but Dan Hamowitz, who's a medical director and physician in Pennsylvania, wrote in a nice comment about communication across the team and with residents and care partners. So thank you for that. Our next speakers are going to be Namali Stone and Kristen Henderson. They're going to talk about infection prevention and management ideas. So Namali, I think we'll turn it over to you.
Thank you very much, Allison. It's such a pleasure to be with all of you this afternoon. Thank you so much for inviting us to be a part of this conversation. You know, I just want to start by saying that every day I am so inspired by the commitment of the caregiving, support staff, providers, administrators who provide ongoing, excellent care to the residents and families and to one another. And I just want to say on behalf of the CDC and our team, we are incredibly grateful for all of you and what you do every day. When I was thinking about what remarks to mention, especially around the concept of innovation. We usually think of doing things new, creating something. And what occurred to me was that the real foundational practices when it comes to detecting and preventing the spread of bacteria or viruses, none of that is really new. But what we saw during the pandemic and what I think we have established in terms of infection prevention infrastructure is some really creative ways to do those fundamentals better, more quickly, more effectively. And so I'm going to just share 3 examples. There are so many more, and I would love to hear from those of you participating today if you have an innovation and strategy or practice that you put into place, please share with us. We always learn so much from your experience. So the first thing we saw was a lot of providers took a team approach to implementing new practices. And we already heard this before from Bobby, and I just felt like, what, as Morgan said, I didn't plan or coordinate any of this in advance, but the real ability to take quickly new information, share it right at the point of care with the team that's going to need that information, give people the opportunity to ask questions, clarify things, and then make sure that they've got the support they need, and also solicit their feedback on what else can we do to make this work for you? How do we do better for you, for the residents and the families you're caring for? How can we help you be most successful? I think that the bringing the solutions, bringing the problems and getting the solutions from your frontline teams was a huge gain in effectiveness. And often we saw the people who knew best how to incorporate those core infection prevention and safety practices at the bedside. They knew what they needed to do it more effectively. The second thing we saw was an incredible expansion of the use of technology. For example, there were a lot of new strategies for screening and early detection of cases. The diagnostic testing and the point of care testing capability that's been established in nursing homes across the country to provide rapid testing for both residents and staff. That's got an application that goes well beyond just the virus that causes COVID, and I think has the power to really protect from many things that sometimes can go unrecognized or delayed in the recognition that we have when they come in the building. So another really expansive infrastructure that we can do much more with than just what we've done for COVID. And the last thing is something, again, that was already mentioned, and that's the new establishment or the strengthening of partnerships that really went beyond just your teams, went beyond just your organizations to the many partners that were trying to be a resource, another way to access information and coordinate supports coming back to facilities. I saw some comments which are very valid that they didn't always go very well. Sometimes the messages that were coming from different partners were slightly different. And then suddenly people felt stuck because who's right in that? I also want to acknowledge that there were a lot of programs, public health programs that were trying to build relationships that ideally would have been in place long ago. And whether it's our coalitions, understanding the needs of nursing home providers, recognizing their critical role and deploying supports and materials to resource our centers, there are improvements that needed to be made. We saw gaps in what happened, but I feel like that also gives us tremendous opportunity to close those gaps, to not go backwards, but actually think about how do we sustain those relationships? How do we sustain those lines of communication that have been built? So I think the theme here, largely around communication, but all of what we have seen you accomplish and want to continue to support you in doing comes from having these kinds of dialogues. So thank you very much.
Thank you, Nimali. And last but not least, Kristen, over to you.
Thank you, and thank you for having me. So my name is Kristen Henderson. I'm the Senior Director for Clinical Services for Presbyterian Senior Care, but I'm also an infection preventionist in long-term care, which means that I've taken some courses, I passed a test, And it's actually the regulation in my industry to have an infection preventionist in each long-term care community. An infection preventionist, for those of you that don't work in long-term care, which I think a lot of us do, but it's just a person who directs the infection control practices in a building. We follow an approved set of policies and procedures. We audit for compliance, for effectiveness. We track antibiotic starts. We count antibiotic days. We audit hand hygiene, monitor isolation, as well as many, many, many other tasks on a daily basis. Our programs are simple and effective, and they are designed to be run independently without oversight. I share information about our requirements as an illustration about long-term care infection preventionists, about what we are able and trained to do. So I was going to start with just a broad view of infection control practices that kind of held us back during the early stages of the pandemic. And then I'd like to zero in on some specific issues that we at Presbyterian Senior Care Network had. And as I mentioned, the issues, which started out as negatives, you'll hear how we turned them into actionable strategies and tactics to deal with the next pathogen. And just incidentally, all of what I'm about to say has already been said. So there's a lot of recurrent themes here. Okay, so when the pandemic hit, there were several issues that we needed to deal with immediately, and we identified all of them as very critical. The first was our lack of immediate access to experts. The second was our inability to provide enough private spaces in which to isolate. And the third was the inability to collect and use large amounts of data in a helpful way. These three key issues played a huge part in our ability to control the disease initially, and I wanted to review each one. So first, our lack of access to experts immediately. And this means both local and like in a larger way. In the first stages of the pandemic, as I mentioned before, I'm an infection preventionist. There are other infection preventionists just like me in all of the long-term care communities in my network. And all of us have about the same base of knowledge, but there was really not one true expert. There was information being thrown at all of us from everyone. We had no North Star and no local medical experts immediately. We each had our medical directors, but that person was not usually an ID specialist, and we couldn't get them to agree on anything, if I'm being honest. So we created a COVID task force with an infection preventionist and a physician on it, amongst many other people, and several of them are actually on this call. So these people were appointed to research, learn, and consolidate all of the info, but we still did not have immediate access to a true ID expert. It wasn't until about a month or so later that the medical community kind of banded together and began to have virtual calls with the long-term care communities, as well as offering access to local regulatory bodies to let us know what the new regulations were, in order to share their expertise. So these informational sessions were life-changing for someone like me. This ability to convene a panel of experts quickly, both broadly and in our local communities, with the purpose of sharing best practices, is something that we appreciated back then, and ever since the pandemic has kind of simmered down a little bit, we continue to take advantage of our experts. So we appreciate all of the big names, right? Like the CDCs, the DOHs, all of them. The second issue, it was the inability to isolate effectively. So given that the majority of rooms in a long-term care have traditional structures, right? Which is like a bigger room with at least 2 beds and a curtain to separate them, or maybe a wall to separate the beds. You know, neither of those situations is remotely ideal for infection control purposes. We were at a disadvantage from the get-go. In fact, one study done by the National Institute of Health showed that during the alpha wave of the pandemic, that smaller greenhouses, which are nursing homes with ideally 10 to 12 beds and universal workers in each space, had far less incidence and mortality from COVID than a traditional nursing home. So, and that is due directly to the fact that fewer people are providing care and that there is availability of private rooms and private bathrooms. So our traditional model required us to get pretty creative with both isolation and quarantine. But to be honest, all communities were operating in a trial and error mode for a little while. Moving forward, things that we learned was for future renovations, we will focus on smaller house models with less residents, universally trained team members, access to outdoor spaces, and better airflow. And then just moving into the third issue was the inability to process and use large amounts of data in a meaningful way. One of our mantras during the early part of the pandemic was to follow the science, even when things didn't seem to make sense to us at the moment. But the truth was, the real science at the time was a moving target, right? Like we all knew that. We were able to gather large amounts of data from our network. We tried really hard to make smart decisions on it. And for example, as you know, in the beginning of the pandemic, the telltale sign was the fever until it wasn't. And then it was the loss of smell and taste. And then it was GI symptoms. And so we know now that the harbinger symptoms changed with the strain of virus. We didn't know that back then. So we, in our network, we created and recreated protocols around the latest data available, only to change it with the next wave. We built elaborate spreadsheets, we tracked symptoms, and we tracked positive cases all by hand. We just weren't equipped to handle the volume. So fast forward a couple years, and now we have symptoms and partners in place to help us sort data, use it in a meaningful way. Another huge challenge was that the public health data systems were also not equipped to handle the volume of data they were requiring, and that did cause confusion at first. Data came too little too late, and until the systems were updated and modernized. They are now, right? So we report to the same databases, and we're able to learn from other successes and failures. And I guess also in this category, I'm including some words about vaccines, not just COVID, but all vaccines. So it sounds so simple, and it sounds very, obvious now, but at the time it was not obvious to us that the faster we have access to vaccines at the community level, the better off we are. So several of our communities have vaccine rates over 80% for residents and staff, and I attribute that to the fact that we did apply to be a COVID vaccine provider. This option was not available to long-term care communities at first, but we now know that this action does make a difference, and we are ready now for the next pathogen whenever it arrives.
That's great. That's great. Kristen, thank you so much. Were you almost at the end?
Yes, absolutely.
Okay.
I was going to say that all long-term care providers should, have a vaccine provider permit and be able to give vaccines at their level. Absolutely. That makes the hugest difference.
Fantastic. Well, I'm going to turn it over to Paul to see if he has some questions and for this discussion. And we really want to hear from all of you. Every one of our speakers was just fantastic. So thank you guys so much for all that information. I also just wanted to mention that Anna Fisher, who's one of our Moving Forward committee co-chairs, and I don't know if Kara Jacob-Slifka is going to be able to join or not. She was on travel, but they're also here to add some comments during the discussion. And I also wanted to point out that Jane Carmody, who's our Senior Program Officer from the John A. Hartford Foundation, I see has joined the call, and Nancy Wexler, also from the John A. Hartford Foundation, are on. So Paul, I'll turn it over to you.
Thanks, Alice. Wow, these presentations were so great, and I hit a spinning. I have so many questions. But one theme that came through really over and over was this idea of collaboration and deep collaboration, very different kind of collaboration, maybe than it ever had been attempted maybe in the past out of necessity, right? And so I'd like to maybe ask a little more around that. One, go back to Dr. Katz, and maybe Nimali might comment too. She referenced the CDC initiative that was interesting, of potential collaboration with academic medical centers. So I want to go there. And then a question to the broader group is, today we're talking about, the skilled nursing care community, but we have assisted living, we have affordable housing communities and CCRCs, and a lot of other parts of the continuum that don't have access to a lot of these kind of resources. And might there also be opportunities for collaboration as we, where the nursing community can be a hub too, as well as if there's a partnership, maybe bigger types of collaboration that go outside of the walls of the skilled nursing community. But maybe Dr. Katz or Namali, the CDC initiative was very interesting to hear about. Is there a little more that you could talk about there? And I also think, by the way, in general, foundations love collaboration. So there could be some really great grant opportunities, I think, and a lot of what we heard today as we think about collaboration in new ways.
Sure. So, I mean, I can elaborate a little bit on the Public Health Response Network. So it's really just getting started. There are 8 cluster sites across the country, including various academic centers. Hopkins is one of them. We've partnered with 10 nursing homes. We're really focusing on 6, but there are, and several other academic centers are involved. Emory, Brown, people that have had experience working with long-term care populations in the past and have some research experience. And again, I think this is a way that we can not only establish this partnership with nursing homes, but we can also start to learn from them and be doing active research and be able to respond just in time when new things arise. I don't know if Namali wants to elaborate further.
Thanks, Morgan, and I should have thanked you for mentioning the Public Health Response Network and the investment, because for a long time, a lot of the work of our agency, especially in infection prevention and healthcare, has been very hospital focused. And so, and even the way we think in this country about healthcare is still very hospital focused. And even though we all know that the healthcare delivery has moved tremendously outside of hospitals, we haven't established quite the same level of support and infrastructure to look for innovation, research opportunities, response supports. And so this network is something I'm very excited that our division has been able to invest in. I think it's, I wish it had happened a long time ago, because we realized, to try to learn as much as we could as quickly as possible from providers, having those relationships established already would have been very valuable. But this is one of our takeaways, is making this investment so that it's sustaining into the future, and we can do ongoing work with providers and tap into the knowledge of people like Dr. Katz and her colleagues across the country who have been working in this space. There's also been a large investment in public health programs in the support of nursing homes. And so there was a $500 million award that was distributed across the country to state and local health departments to specifically work on COVID prevention and support, including workforce supports in nursing homes and other long-term care settings, including assisted living and residential care. And I mentioned that because, I think there's some very innovative work that our health departments have been trying to get established, that are around engaging new and incentivizing new people to come into the workforce and to retain strong direct care workers once they've come into centers, because the value of those folks is so high and that they're essential. So these are hopefully going to be continued investments that the public health and CDC are going to make. Thanks.
Thank you, Namali. And this is a great part of this conversation, right? So talking about public health, talking about, hospitals and health systems, and how all of us and our partners and our colleagues and every person needs to be advocating for nursing homes, assisted living, home care, every single setting of care. It's not just about hospitals, and hospitals have been good partners in lots of this work. They're involved in the Moving Forward Coalition. Many of you, some are on this call. I'd also like to point out that this call has a wonderfully diverse group. We have geriatricians, we have people from QIOs, we have nursing home residents, many of them. We have, people who do physical plant and related work. We have advocates and professional associations and ombudsmen and others. So this is an example of the diversity that we need. We need to get everybody and the unusual suspects to come out and talk about the issues. We need to advocate and get in front of everyone who may not know about nursing homes and the quality issues, and inform them as you guys are informing us today. So Paul, back to you, but I just wanted to point out those things.
Really great points, Alice. Thank you. Maybe on Bobby, maybe a call on you, because I know you did a lot of thought on this. Is this idea, someone put up a message that we could do a whole session on assisted living and ways to really partner there. I wonder if you might want to comment on the assisted living, the affordable low-income senior housing world, or other national opportunities. And also, we haven't really talked about dementia here today, but dementia is a confounder in everything, right? And that created a particular challenge. Wonder if also maybe you could comment on that.
So I noticed from the chat, it was different in every state. In Pennsylvania, personal care assisted living did follow much the same regulations as skilled nursing. And, we've definitely seen the acuity in assisted living and personal care increase dramatically over the last several years. It used to be people, drove and they, were very functional. Now it's very, our length of stay is down to less than a year in some cases, because people have waited so long, especially during the pandemic, to go into assisted living. So, I'd agree with whoever said, full conversation around that would definitely be interesting. I think the most terrifying thing we faced in terms of taking care of people during the pandemic were those living with dementia, because we knew there was no masking there, there was no quarantining. It was very, very challenging. And the fact that, the outcomes were not worse is a godsend, really. So, even though we have private rooms in dementia care, you just don't quarantine those folks. So how do we do isolation, and how do we keep people safe during times of outbreak? That could be a whole topic as well.
Yeah, that's, and I just chatted in that Doug Pace from the Alzheimer's Association is one person as a member of our coalition who is specific, his specific work is related to dementia, but we have lots of other people on this call and on the Moving Forward Coalition who really bring that expertise. So I know we're getting short on time, but Paul, if it's okay, I wanted to call on Anna Fisher. Anna, just would love to hear any thoughts that you have in helping us wrap up today from your work in the nursing homes.
Boots on the ground as we speak right now. I'm a nurse, everyone, as well. A couple of things that I really want to emphasize. Communication is the silver lining, the silver thread throughout all of this. The pandemic has shown a spotlight on the need for collaborative efforts. A couple of things here. Once you take on that resident, that patient, that client, any of that, you take on that entire family. I can't emphasize that enough. So it's important, not only are we providing that care for the patient, the resident, we need to take care of the families, the children, and what are we doing to support that as well? Resources galore, have hotlines, helplines, resources, packets available for individuals as they navigate this. I know there was a comment made early on. I see this lasting for quite a while. It'll be a different strain, a different variant, and no longer can that be an excuse. What are we doing to deal with it in the moment and still give our precious people a high quality of life? So Alice, I think, we need to be champions and we need to be open-minded on what works one day may not work today. That's one thing, especially with our precious residents in our memory care. Oh my goodness. I can't tell you, how passionate I am, Alice, when they say, oh, Dr. Fisher, won't you take off your mask? I want to see you before I pass or something. and, you know, your heart aches.
Yeah.
But I think the challenge, I'll conclude on this, everyone. I think the challenge, what we're faced with is we want to give and create a home-like environment, a high quality of life. That's how I would want to be treated. However, we have to deal with regulations. We must wear source control and N95s. And so it's finding that balance. And I'm going to be the biggest champion, everyone. Life is so precious. We can do this. So thank you, Alice.
Thank you. And Anna is one of our champion co-chairs of and work group leaders. So thank you so much. I know we're almost at time, and Paul, if it's okay, I want to just
mention one other thing before I head back.
Go ahead.
A great resource out there that some of you may know, Jewish Healthcare Foundation funded a documentary titled "What COVID Exposed in Long-Term Care." You get a chance, it's really excellent. And finally, just want to say special thanks to Alice Bonner and Erica Hornstein for great work in proposing this and planning it. Thank you.
Well, thank you, Paul. And I'll turn it and say back at you. This was Paul's idea for people to know. So this was his brainchild. And Erica, a million thanks for putting it together. Erica's also putting information into the chat about the next coalition conversation. So we have another couple on tap that are coming up. One is on cost reports. Another one is going to be on how we can all be advocates and continue this work together. So we hope you'll continue to join. This was just a fabulous conversation today. I'm so glad we recorded the call. In closing us out, I wanted to see Jane Carmody, since you're on the call, if you have a moment and can close us out, we would love to hear from you. I know Nancy's on too.
Can you hear me, Alice?
Yes, ma'am, we can.
Oh, well, I'm on my iPhone. Sorry about that. Ended up doing that, and I'm late, but oh my gosh, Alice, this was an amazing call. Learned so much, and it reminded me of a lot of things I've heard in our work in public health and with our community-based organizations that COVID-19 brought them together, but the relationships will make them stay together. So that's what I kind of heard throughout the day. Wow, this is great. I'm so glad you recorded so I could pick up the rest of it. The foundation, Alice, as you know, is honored to support this work, and we know it's going to make an improvement in nursing homes.
Fabulous. Great way to end the call. So again, thanks to all of you. You're doing the work out there. Thanks to all of our fantastic speakers. You just really, you continue to inspire us. Isaac, thanks to you for all of your direction of the program as well. And, keep your cards and messages coming. We love to get your emails. We hear from people every week, new folks who are joining. So with that, it's exactly 3 o'clock, and have a great weekend and rest of your week. And we'll talk to you all soon. Thanks.
Thank you.
Take care.
Thank you so much. Excellent.
Thank you, everybody. Good seeing you. Everybody, please stay safe.
Thanks all.